Cool. Hi, everyone. Just going to share my screen. So, Sanjana, can you see that?
Yeah, I can see that.
Perfect. Okay, cool. We'll make a start. So my name's Sabrina. I'm one of the general surgery reggers at Kingston, and I'm going to do a session today, lecture-based on GI surgery and breast disease. So this is your T-year syllabus for GI surgery and breast. So there's far too much for us to cover completely in 90 minutes, but hopefully I'm going to be able to go over some of the more important things with you today. So this is how the structure is going to work. The lecture is going to be in 3 parts, and then at the end of each part, there'll be 3 MCQs, and then we're going to take a short break. So in part 1, we're going to talk about acute abdomen and in particular bowel obstruction. Then we'll cover acute appendicitis and diverticular disease. So the acute abdomen, it's a massive topic, and it can basically be defined as any cause of sudden onset severe abdominal pain. So you're probably familiar with this diagram, with splitting the abdomen into sections and thinking about the differentials based on location. So I'm not going to dwell on this now, but it's worth you familiarizing yourself with this. Another way to think about the acute abdomen is dividing things by pathology. So the things I've highlighted in red are things that I think it's really important for you to know about, and these things shouldn't be missed. So in terms of bleeding, ruptured AAA, so abdominal aortic aneurysm, ruptured ectopic pregnancy, and then in terms of ischemia, bowel ischemia, and I've also included testicular and ovarian torsion in this because that's essentially what's happening to that organ when it gets torted. It's becoming ischemic. Perforations are important. Obstruction. So when we think of obstruction, we usually think of small bowel and large bowel obstruction, but I've also included biliary and ureteric colic in this because it's essentially also a hollow viscus that's been obstructed by a stone, and that's what's causing the pain. In terms of inflammation and infection, basically any organ inside the abdomen can become infected or inflamed. And it's also really important to not forget the non-surgical causes of abdominal pain, of which there are many, but important ones are DKA, pneumonia, and in anyone with epigastric pain, it's really important to exclude an MI. So in terms of key points for your exams, any female of childbearing age presenting with abdominal pain, it's essential that you exclude an ectopic pregnancy, so they all need to have a beta HCG. Abdominal pain in young males, it's really important to exclude testicular torsion, and you should always have a really high index of suspicion for a ruptured AAA. So this tends to be a middle-aged male presenting with vague abdominal back or flank pain, pulsatile abdominal mass, and the patient's usually very unwell and shocked with hypertension. And as I said, you need to remember non-surgical causes of abdominal pain. So in particular in epigastric pain, we shouldn't be missing an MI. So now I'm going to talk about bowel obstruction. So we can divide bowel obstruction into small bowel obstruction and large bowel obstruction. And then within that, we can think about mechanical and non-mechanical obstruction. So when we say bowel obstruction, we usually mean mechanical obstruction. And by that, I mean any structural pathology that physically blocks the passage of intestinal contents. And this can be divided into intraluminal causes, mural causes, and extramural causes. By non-mechanical bowel obstruction, I mean functional obstruction, where there's no physical blockage, but the bowels aren't working properly. I'm not going to go into this in too much detail, but it's just worth you being aware of the 2 causes, so paralytic ileus and pseudo-obstruction. So causes of mechanical bowel obstruction, if you take anything away from this, it's important for you to know that the key causes of small bowel obstruction are adhesions, so that's usually scar tissue post-op. and hernias. And for large bowel obstruction, it's strictures, malignancy, and volvulus. And it's more common to have a sigmoid rather than a cecal volvulus. And then, as I mentioned, there's intramural, mural, and extramural causes. I'm not going to read all those out for you, but it's just something for you to be aware of. So in terms of the presentation, your key features of bowel obstruction are going to be vomiting. If the bowel obstruction is proximal, the patient will present with vomiting early. And if the bowel obstruction is distal, vomiting is going to be a later feature. The vomiting will start off as gastric contents. It will then become bilious, so green colour, and then eventually it will become feculent. The patients have abdominal distension and they also have absolute constipation. So by this, I mean they're not passing stool and they're not passing any flatus either. They tend to have a colicky central or suprapubic abdominal pain. On examination, apart from having a distended and tympanic abdomen, they're going to have these tinkling, mechanical high-pitched bowel sounds. So in terms of investigations, all patients presenting with acute abdomen should have a full set of bloods, but things to look out for in bowel obstruction, patients often have a slightly raised white cell count. Patients lose lots of fluid into the bowel, so they can have deranged electrolytes and AKI. And it's important to look at the lactate and for any acidosis on a VBG, because that can indicate the health of the bowel. In terms of imaging, all these patients will usually undergo an abdominal film followed by a CT abdo-pelvis, and sometimes we also do water-soluble contrast studies. So looking at X-rays is something that often comes up in exams, and the difference between small and large bowel obstruction. So for small bowel obstruction, and in terms of diameter, anything more than 3 centimeters is abnormal. And for large bowel obstruction, anything more than 6 centimeters is abnormal, or at the cecum, 9 centimeters. The bowel loops, as you can see on the X-rays here, they tend to be, for small bowel obstruction, tend to be centrally located, and there are many loops. And then for large bowel obstruction, the dilated loops tend to be more peripheral, and there are fewer of them. In terms of the marking, small bowel obstruction, you get these valvulae conniventes, which are where the lines go completely across the bowel. And in large bowel obstruction, you get haustra, which are lines that only partially cross the bowel. In terms of management, we can split this into conservative, interventional, and surgical. So conservative, all patients should undergo drip and suck. So this is a NG tube or a Ryle's tube, and IV fluids. They should be catheterized and they should be kept nil by mouth. In terms of interventions, that depends on the cause of the bowel obstruction. So, for example, in patients with adhesional bowel obstruction, we can try a water-soluble contrast study that can help define where the blockage is, and sometimes can even relieve the blockage. For patients with sigmoid volvulus, we can do a sigmoidoscopy and place a flatus tube to decompress the bowel. And in large bowel tumours and strictures, we can do stenting. Many of these patients will need to go on to have surgery, not all of them, some of them. And the surgery we do depends on the problem. So, for example, we might need to divide adhesions, repair hernias, or sometimes resect bowel. Points that often come up in exams, you need to know your 4 cardinal features of bowel obstruction. So vomiting, absolute constipation, abdominal distension, and colicky abdominal pain. For small bowel obstruction, remember it's adhesions and hernias. And for large bowel obstruction, malignancy, strictures, and volvulus. And for sigmoid volvulus, this often happens in elderly, and you can see this coffee bean sign on X-ray. So moving on, we'll start talking about acute appendicitis. So this is inflammation of the appendix, and it's the commonest abdominal emergency. So pathophysiology, acute appendicitis is often caused by blockage of the appendix lumen, and usually this is by a fecalith, so a small piece of stool that gets stuck in the lumen. You then get bacterial proliferation, pressure necrosis, and then eventually you'll get gangrene and perforation of the appendix. In terms of the presentation, the classical presentation is this migratory right iliac fossa pain, which starts with a central periumbilical colicky pain and then shifts to the right iliac fossa. Patients are nauseous, they sometimes have vomiting, and they also have anorexia. And occasionally patients will complain of constipation or diarrhea as well, but it's not usually a key feature. In terms of the examination, patients often have a low-grade pyrexia that can be tachycardic, and they have right iliac fossa tenderness and guarding over McBurney's point. So to recap, McBurney's point is 2/3 of the way along a line from the umbilicus to the anterior superior iliac spine. There are a few eponymous signs that sometimes come up in exams related to appendicitis. So Rovsing sign is patients having pain in the right iliac fossa on palpation of the left iliac fossa. The psoas sign is where patients have extension, they have pain on extension of the right hip, and that suggests a posterior retrocecal appendix. And Cope sign is when patients have pain on flexion and internal rotation of the right hip, and that's due to an appendix abutting the obturator internus. So there are many differentials for right iliac fossa pain, and I'm not going to read this list out to you, but it's just important to be aware of them. A couple of key ones that I will mention are mesenteric adenitis in children. So any child that's had recent coryza, cough and cold symptoms, an important differential is mesenteric adenitis. And in any female of childbearing age who's had sudden onset pain, it's important to think of ovarian pathology. So ovarian torsion, ectopic pregnancy, and cyst accidents. So in terms of investigations, bedside tests, all patients should have a urinalysis. So beta HCG in females, and you might find that patients have leukocytes and blood in the urine, and this can happen if the appendix is lying over the bladder and irritating it. Bloods, you're going to be looking for raised inflammatory markers, so white cell count and CRP. Not every patient needs imaging, so often you can make the diagnosis clinically, but sometimes ultrasound abdomen and pelvis can be useful in children or slim adults, and in females to exclude gynepathology. If there's any doubt, or especially in older patients, we can do a CT abdo-pelvis, which is a sensitive and specific test. In terms of management, this can be conservative, medical, and surgical. So conservative, we can keep the patient nil by mouth, give IV fluids. Medically, we'll give IV antibiotics, so this tends to be co-amoxiclav or something like amoxicillin, metronidazole, and gentamicin. Analgesia, antiemetics. And then most patients will undergo an appendicectomy, so this can be laparoscopic or open with a Lanz or gridiron incision. Sometimes we do non-operative management, so this tends to be in elderly or very comorbid patients, or patients with an appendix mass, which I will talk about next. So appendix mass is a possible complication of acute appendicitis. So these are patients that often present a bit later, maybe after 4 or 5 days of pain. And on examination, they have a right iliac fossa mass, and they tend to be reasonably well. And this is because the appendix has been walled off by mentum and adhesions. To operate at this stage, it's technically very difficult. So we tend to treat these patients with antibiotics, pursue radiological guided drainage of any abscesses, and then we bring them back in about 6 to 8 weeks for an interval scan, and we may take their appendix out at that time. So we're going to move on now to talk about diverticular disease, and I just want to start off by going through some definitions. So a false diverticulum is an outpouching of the bowel that only includes the mucosa and the submucosa and doesn't include the muscular layer. And these include colonic diverticulum, which is what we talk about when we talk about diverticular disease. A true diverticulum is an outpouching of all layers of the bowel wall, and examples of this would be a Mcqs diverticulum or a jejunal diverticulum. Further definitions, so we've got diverticulosis, so this is the presence of colonic diverticuli, and diverticuli is just the plural of diverticulum. And that's when the disease is asymptomatic. As soon as patients have any symptoms or problems from the presence of diverticulosis, this is called diverticular disease. And diverticulitis is when a diverticulum becomes inflamed. In terms of features, we've said it's a false diverticulum. It becomes more common with increasing age, and it usually affects the sigmoid and descending colon. It can happen on the right, but that's more rare. In terms of the pathophysiology, the diverticulae occur at potential sites of weakness in the bowel, which correspond to entry points of vessels supplying the bowel. And if you get erosion into a nearby vessel, that's why you would have bleeding with diverticular disease. So the most common cause is a low fibre diet, but other causes can be structural abnormalities, such as connective tissue disorders, and also dysmotility. So diverticular disease has several key presentations. The one I'm going to focus on is acute diverticulitis. So this is where patients will present with a lower central abdominal pain, and usually most of the pain's in the left iliac fossa. Sometimes they can be quite unwell with fever and vomiting, and on examination they may be peritonitic in the left iliac fossa. And if this progresses, it can lead to a perforation. Patients may present with large bowel obstruction, and the patients can have an inflammatory fibrosis, which leads to stricturing. Patients may present with hemorrhage. They don't tend to present with acute diverticulitis and hemorrhage at the same time. That tends to be, they tend to present with just one or the other. So when they present with hemorrhage, that's due to an erosion of a vessel in the diverticulum, and it's usually a profuse bright red bleed, common in the elderly. Patients might have chronic diverticular disease, so they have change in bowel habit over a period of months or years with diarrhea and constipation. They can have blood and mucus in the stool, and sometimes there's a mass palpable in the left iliac fossa. And it's really important to exclude a colorectal cancer in these patients. And then you can also have a colovesical fistula, of which diverticular disease is the commonest cause. So that's an abnormal connection between the colon and the bladder. And these patients present with pneumaturia, so gas and fecal debris in the urine, and they get recurrent UTIs. So in terms of investigations, blood tests, these patients may have raised inflammatory markers in acute diverticulitis. In terms of imaging, the most useful imaging is a CT abdo-pelvis, which is used in the acute setting, and that can diagnose acute appendicitis and any complications of that. You can do a CT colonography to look for any strictures or fistulae, and all these patients should eventually undergo a sigmoidoscopy or colonoscopy to clarify the diagnosis. This shouldn't be done in acutely when the patient has acute inflammation, because this can risk perforation, so it should be done about 4 to 6 weeks later. And in terms of management for acute diverticulitis, this can be conservative medical, special or surgical. So conservative, we give oral or IV antibiotics, so usually cefuroxime, metronidazole, gentamicin. The patients will go on a liquid diet initially. If there's an abscess in the abdomen, we can pursue a radiological guided drainage of this. And some patients who have quite severe acute diverticulitis or perforations may need surgery. So this might be a laparoscopic washout, or it might be a Hartmann's procedure, which you can see in the diagram, which is a sigmoid colectomy with an end colostomy. So now we're going to go through some MCQs. So I'm going to give you some chance to read the question, and then there's going to be a poll, and then we'll go through the answer. Okay, so I can see that the most common answer was E, followed by A. So I can confirm that the answer was in fact E, and we'll go through why that is the case. So, and you've got an older gentleman presenting with essential colicky abdominal pain and vomiting, dark red bleeding from the rectum. So if we look through those differentials, it's not going to be B, you don't really get bleeding with small bowel obstruction. Perforated pepticle, so that doesn't really fit either. And diverticulosis, we've just discussed, that's only an asymptomatic definition. So it's going to be A or E. Now, it says here the patient's got chronic atrial fibrillation, which is untreated, and that puts the risk of forming clots, which can break off and embolize. So the suggestion here is the patient's got untreated AF, and a clot has gone into one of the vessels of the aorta and caused ischemic bowel. The fact that he's unwell, agreed, it could be consistent with perforated diverticulitis and diverticulitis and a high lactate, but in that situation you wouldn't usually get so much bleeding. And often in patients with acute mesenteric ischemia, they're very unwell, but they don't have lots of abdominal signs. And in this question, it says the abdomen's soft, but generally tender, whereas in perforated diverticulitis, the patient would usually be peritonitic. Okay, so we'll move on to the next question. Okay, so nearly all of you answered this correctly. So urinary beta-HCG. So we've got a 29-year-old female, so female of childbearing age with right iliac fossa pain. So a ruptured ectopic pregnancy should be right at the top of your differential. She's also sweaty and tachycardic, which suggests she's unwell. And she's also unsure of the date of her last period. So it's really important that we rule out a ruptured ectopic pregnancy as soon as possible, because that's probably the most likely thing that will kill her. So that's why beta-HCG is probably the most important initial investigation. All of the other investigations might be useful for this patient, but the urinary beta-HCG is definitely one of the most important. Okay, and then the final question in this part. Okay, so I can see that the most popular answers were A and D. And the answer to this question was D, large bowel obstruction. So going through the question, we can pick out some of the key features of bowel obstruction in this. So colicky abdominal pain, absolute constipation for 2 days, and marked abdominal distension with increased bowel sounds. So that's all sounding like some sort of bowel obstruction. Now, the fact that it says that the patient's nauseous but hasn't vomited, but she's had this absolute constipation for 2 days, that's what makes you lean towards a large bowel rather than a small bowel obstruction. Because as we said, in a small bowel obstruction, something a bit more proximal, the patients tend to vomit early. And in a large bowel obstruction, it will take a bit longer for that fluid to back up into the stomach. So they tend to vomit a bit later in their presentation.
Thanks for watching. Don't forget to like and subscribe. If you're watching this on YouTube, head to our website to watch the next part. If you're already there, just mark this part as complete.